So this one's more of like a prioritization delegation question. Sometimes they'll do this. So they'll say something like, okay, so you have three patients who are on the call bell.
Mhm.
The first patient is complaining of the chest pain that they came in for, 10
Okay.
out of 10 chest pain. And then the second patient is the patient that came in with a fall, saying they need to have a bowel movement right now. And then
Hmm.
the third patient, you actually can't tell what it is that they're saying because they're not making any sense. So for
Okay.
these three patients, like how would you prioritize and delegate?
Um, so for the patient who's like slurred speech, is that how they came in, or is
No.
this like it's not? Okay, so it's like a new thing.
Mm-hmm.
Okay. So I definitely see the patient with the new onset. It's an acute issue and always prioritize acute over chronic. And I feel like my second would be the chest pain person, because his pain is really high and we definitely want to give him pain medications as needed. But between those two, I definitely do the new onset of symptoms just because with what I've learned prioritization wise, always, acute over chronic. And then for the patient that needs to use the restroom, you said, right? Was
Mm-hmm.
that what it was? No, what did you say? Yeah.
Yeah.
With that, I feel like I could delegate that to someone else, like a CNA.
Yeah.
I mean, I could do that too, but I would go see the first two first.
Yeah. Yeah. So you could say something like, I would ask the nursing assistant if they could check in on the patient with the falls history that needs to go to the bathroom right now. And
Okay.
then if there was a nurse next to me that wasn't busy or a charge nurse who could help me out, I would ask that they could just lay eyes on the patient with the recurring chest pain, just grab a set of vitals, tell them I'll be there in a second. That way, if there is anything new, at least they would have a nurse there um, to check in on them. But my priority would be to first go see the person who is not making any sense, just to make sure that this isn't like a new concerning neuro change.
Okay.
Um, and then tell me, like, imagine they were asking you, like, what would you do if you came in and your patient had slurred speech or was confused? So walk me through like what your process would be, like start to finish for that.
Okay. If they had slurred speech and new confusion, I would definitely first just I would probably check their chart just to see like if there's any kind of diagnosis that kind of correlates with these symptoms.
Be
If
careful with that. So
okay,
say, I would review in my head what I had learned about them in report, but like
okay,
don't make it sound like you're removing yourself from the situation. Like you want it to seem like you're there doing your nurse
yeah,
thing. Yeah.
absolutely. I guess in my head I'm so used to the computers that go along with us, but but no, I like the better like review the chart beforehand and then just, correlate that to what's going on with the patient
Just
right
kind of
now.
like reflect back on what you read previously about the patient.
Yeah, okay.
Yeah, okay. So I'll let you start with that.
Okay. Yeah, and then after that, if I didn't make any, connection there, I would go ahead and I would assess the patient. Definitely want to check their vitals first, see if everything's stable there, oxygen level, all of that. After that, I would do a blood glucose check, just because I feel like that can also be something that is going to cause those symptoms. If both of those are normal, then I would probably more lean towards like evaluating for like a stroke. So kind of doing the stroke. What is it fast, right?
You
I
could just
forgot
say,
what
I
the
would just do a neuro check just to make sure there's
okay.
no focal deficits.
Okay. But yeah, I would do a neuro check. So
And
there's
like just in case they grill you on that, which they probably won't. I like being vague with it because like let's say you say how you do your neuro assessment, and let's say it's different from how they do it. They might
that's
think
very
yours is
true.
wrong. So I like to go vague and say like I do a quick neuro assessment, but like personally what I would do is I would see if like they can talk to me, if they're making sense, if they're oriented, and then while I'm doing that I'll see if they can follow commands by doing like checking their pupils, asking them to smile, do like the pronator drift test and do like,
Okay.
can you push, pull, shoulder shrug? Can
Mhm.
you move both your legs and these do like step on my hands, pull your toes up towards your face kind of thing. Um,
But should I
and
just initially say neuro assessment? And if they ask in depth, then I can
then you can say kind
go.
of like what you would do. But
Yeah,
that's
yeah.
just so you
Okay.
know, that's kind of like the standard on the step down.
Okay.
Yeah.
Um,
Um, by the way, just side note, do you have your ACLS?
I'm actually getting it in a month. I was supposed to get
Okay.
it this week, but I had an interview, this interview. So
Okay.
I
That's
was like,
good. So
let
like
me do
if
the
they bring
interview
it
first.
up, you can be like, I'm scheduled to take it on this. For
Okay.
sure on a step down you would need it. But anyway, so just say like I would do a neuro check just to make sure there are no neuro changes or like no focal deficits.
Okay.
And then if there were any, what would you do? Like let's say they had
Um,
like a new facial droop or something, what would you do?
I would probably call the doctor and let him know of the new assessment that I found and ask him what his, what's the word I'm looking for right now?
You would
What
need him
his,
to come to bedside, like right
yeah,
then. Yeah.
yeah, okay. Tell the doctor to come
I
down.
would request that he come to bedside to please
Okay.
assess.
Sounds good. Okay. Because
And
I
then
guess at that point, you not be asking for recommendation. You need to come down here.
yeah. Um,
Okay.
and then you could say I would use whatever workflow is appropriate for escalating a possible stroke to prepare the patient for CT and possibly
Okay.
get a neurologist or rapid response at bedside. And then you can also say, just for bonus points, you would make sure that they have good IV access while you're waiting
Oh,
for
okay, yeah.
the stroke team to arrive after you've done your assessments.
Okay.
While you continue to like talk with them and assess
Monitor.
as you're
Yeah.
talking. Yeah. You could also say like if they weren't in bed, I would like safely get them to bed just in case.
Just ensure their safety.
Yeah.
Okay.
Um, okay. And then so for the chest pain, when like you would say like after I had appropriately assessed and escalated that situation, the neuro change situation, I'd go to I'd check in with the nurse who had assessed that patient, thank them, and then see if there's anything that they had noticed, and then make sure the vital signs were stable, that the patient, like even though they are having coronary issues, like they're able to perfuse properly. And then I would give them, if they had like a standing nitro order, I would give that, reassess, see if they need, 2 or 3 doses. And if the pain was not controlled by the nitro, we definitely need to escalate that. Retaking the blood pressure prior to each dose just to make sure they can handle
Yeah.
another dose.
Okay.
And then depending upon how many doses they need, would dictate how I let the doctor know, patient's vital signs are stable, gave 1 dose of nitro. Let me know if you'd like any workup at this time versus, chest pain 10 out of 10 unresolved by PRN nitro ×3. Please come to bedside to assess. Would you like an EKG? To just kind of like let that and the doctor's recommendations guide how I proceed from there.
Okay.
Yeah. Because the doctor might say, like, I mean, their troponins are downtrending. They've already peaked. They're downtrending. Like, cardiac workup was negative. We don't need another EKG because we just got one an hour ago. Like, it kind of depends. Versus if
Yeah.
it's new chest pain, they'll want tropes, maybe a BNP. They'll want lights.
Mm.
They'll want you to put them on tele, do an EKG, like all kinds of stuff.
Okay.
It's like you said, like acute versus chronic.
Yeah. I'm like, that always just, I swear that's the only reason why I passed my NCLEX. I'm just kidding.
uh yeah, it's always so weird when you're like, wait, chest pain's bad, right? That's the one you circle as the correct answer. Oh,
Yeah.
all we do is just give another dose of nitro and check the pressure. Doctor doesn't care. Weird. Okay. Like,
Yeah, right. It's like, yeah,
yeah.
no, that's like my biggest thing. I was always just like, okay, well, if it's an expected symptom, that's not the one. Like,
Right.
choose something else.
Right. Yeah, 100%. Okay, so they could do like what would you do if you came into your patient's room and um they you noticed increased work of breathing and they had cyanosis around their mouth?
Okay. I would check for a pulse. Um, yeah, so I'd go in, check for a pulse, make sure, try to like wake them up and see if they're rousable. Um, if they will, then at that point, and well, hold on here. If they don't have a pulse, obviously we're gonna go ahead and start compressions. Um, if they do have a pulse and they're just unresponsive, then I'm gonna make sure to check their vitals, make sure what their oxygen level is, check all of that, breathing, and
What if
then
their oxygen's
uh,
like 78? What would you do?
if it's 78, I would want to call the rapid response team. If
Knowing that they also have a respiratory therapist with them, probably.
Oh, okay. Well, I would call the respiratory therapist. Okay, so maybe it's like if they
Well,
have a
but rapid,
respiratory.
like rapid is better for this because it is like an acutely or it's like a clinically deteriorating situation that you need immediate help for, but you get a 2-for-1 with that. You get like the rapid response nurse to help you, as well as an RT
Okay.
rather than just calling the RT.
Yeah.
Yeah. Um, and then so let's say they were on like 2 liters. What would you do in the
They're on.
meantime while you wait for rapid?
I would make sure there's not any like kinks or anything that's like causing an obstruction
Not
and
like
make sure.
unplugged,
Yeah,
no airway
exactly. Yeah.
obstruction, maybe sit them up.
Yeah, exactly.
And like, what if, so everything's flowing, they're on 2 liters. What are you going to do like in the meantime before rapid gets there in terms of like escalating their oxygen?
Um,
So usually
that's a great
titrate to
question.
like, we usually titrate to 92%. And
Okay.
it's really interesting because I've helped some people who are interviewing in Canada and they are like not allowed to go beyond 6 liters. But like for
Oh,
me, what I would do is I would crank them up to 6 liters.
okay.
Just, they're already hooked up to the nasal cannula, like do 6 liters. If that doesn't like immediately give them a bump, I would very like if they're in the 70s, I would pretty quickly like as long as they're ventilating, like they don't need to
Hmm.
be bagged if they are like physically breathing, right? If they're breathing and just like not saturating, I would put a non-rebreather and I would
Okay.
put it flush to 15, all the way up to 15.
Okay.
And if they resaturated, I would slowly like titrate it back down
Yeah.
to about 92. But assuming they didn't have COPD, and then I would start wondering like what is causing this acute change, right? Like, do they have a PE? Do they have like flash pulmonary edema? Like, why is it that this same amount of oxygen is not helping them like oxygenate their blood?
Right.
Um, and besides sitting them up, I what I really need is I need the doctor to be here. So I would let them know of any vital signs changes, any changes in mentation, and then let them know the current sat on the current oxygen level.
Okay.
Ask that they come to bedside and see if they want to order like a stat blood gas or a
Okay.
chest x-ray,
Okay.
or any other labs or imaging. Like they might want like a CTPE, they might want
Hmm.
I don't know, CBC to see if it's like an infection thing. That would be
Okay.
pretty quick for like pneumonia to just like spiral
Yeah.
like that. My most likely thing would probably be like a clot or
Mhm.
like flash pulmonary edema.
So if
Um,
you are thinking that like it's a clot, what would you do as a nurse? Just oxygenate them as best as you can, right?
yeah,
And then
yeah.
okay.
And then try to see, if you can quickly get like whatever imaging you need to confirm that. As
Okay.
imaging, and then there's also things that can like let you know that like they might order like a D dimer or uh,
Okay. Yeah, yeah,
something
yeah.
like that. Yeah.
How long
Or
have
the
you been a nurse for?
CTPE will
Sorry.
show like blocked blood flow to that area.
Okay.
Yeah.
How long have you
Um,
been in for? You're so
for
sorry. I just had
years,
for how long?
4 years.
Oh, okay. Yeah, I was like, wow, you're just so like knowledgeable. I feel like I'm just so like you see, I'm like I'm glad that, I'm having this conversation with you because you're a very good person to have this conversation with.
Thanks. Um, I mean, it's just kind of like, why are they blue? Like, they're not getting
Hmm.
oxygen. Like, why is it like, are they not? You have to kind of think like, is it too much fluid in the lungs? Is it that like the blood is not circulating in the lungs to like pick up the to even like participate in the gas exchange? Like, what is it? And those are
Okay.
the probably the two most common things that I see. Um, what else? What would you do if you came into your patient's room? Well, I'm gonna make this our last one because I feel like we're like way over.
Yeah.
So, and there's like a bunch of examples like these, like in the videos that I sent you with the clinical scenarios. There's a couple different ones in each of the videos. So you can like hear it, say, like pause it, say what your answer would be, and then hear like the other person like see their answer and like what was added to it. So you walk into your patient's room and they appear to be asleep. But you see a large area of blood. You can't tell if it's like maybe they vomited it or where it might be coming from.
Okay. Ooh,
What would
that's
you
a good
do?
one. Go in, check the patient, see if they have a pulse first. Definitely, I would call for help in that situation. Seems like a call for help situation.
And when you say
Um,
call for help, you can be more specific about it and say like, yeah, like charge nurse, and maybe ask if while I'm working them up, if they could also get rapid response at bedside if it's a large quantity of blood and if vitals aren't looking adequate. Yeah, so okay, I'll
okay.
let you keep going.
Yeah. No, it's
So
okay. Yeah.
help.
So vitals.
Yeah,
Yeah.
100%.
Health,
Always start with
vitals.
vitals. You'll never
Um,
lose points for starting with vitals.
yeah, that's true. Seeing if they're arousable. If they're not, then we're gonna what did I say? Yeah. So if they're not awake, we're checking the vitals. And if their vitals are looking good, then we're going to assess for any injuries that are causing the blood and where it's coming from. Um, and at that point, if it's coming from an injury, it depends on where the injury is. I would definitely, I mean, actually, no, I would want to apply, if it's something like where I can see, I definitely want to apply pressure if it's still bleeding, just keep pressure on that area until I can get some other kind of help. And if, patients, let's say like desatting or has like low oxygen, definitely make sure they're well oxygenated, especially with blood loss like that. Um, yeah, I can't think of anything else.
Yeah.
Wow, I've never been put in terrible situations like this.
So it's like you don't know if so like trying to see if maybe they can tell you like is it vomit, like where is this coming
Okay.
from, like try to assess, make sure like their saturation is good, there's no like airway obstruction. Sit them
Mm,
up just in case, like to protect them from any kind of like aspiration, and then like apply pressure on any bleeding that you do see if they're still actively bleeding, and then you want to make sure their blood pressure isn't too low, like their heart rate isn't too high, just to kind of
okay.
tell you like how serious the bleeding is, how much blood loss they might have had. And then it's definitely something that you would want rapid response there for, and you'd want to let the doctor know um
Yeah.
like how much blood had been lost, like any changes in mentation or vital signs. Ask
Okay.
if they can come to bedside and see if they want like a type and screen or like blood or fluids given or any other labs or imaging.
Okay.
And
And
ask them
say
to
the
come to
patient
bedside.
was like, say the patient was all of a sudden arousable and able to tell you like, oh, this was vomited blood. I
Yeah.
would still probably proceed to do the same things.
Yeah.
I mean, obviously let the provider know because vomiting blood is never a good sign.
Yeah.
But would I still call rapid
Yeah.
response in
Yeah,
that
for sure.
situation? Okay. Okay.
And then like the color of the blood kind of tells you like how far it traveled or like how digested it is, you know, like
Okay.
is it frank red blood or does it look kind of more like coffee grounds?
Okay. Yeah,
Kind of tell you like
definitely.
where they're bleeding from. Like, is it esophageal varices? Maybe is it like a
Okay.
like a stomach bleed? Like,
Yeah. So assess
um,
like the quality of the blood.
yeah, quality, color. I would for sure say color.
Color.
Um, and like, so I used to they as a new grad, they'd always be like I would tell my charge because I knew I was supposed to tell my charge when something bad happened and I needed help, and they'd be like, "Well, did you tell Rapid?" And I'd be like, "Oh, well, no, I will. I just wanted to tell you first."
Yeah.
And then so like sometimes I would be like, I told Rapid, also this is what's happening. And they'd be like, why'd you tell Rapid for that? And I'd be like, I
Yeah.
don't know, because
That's
you
what
guys
I'm
always
afraid of.
yeah, like so I learned the really safe verbiage for that is I looped Rapid in just to see if they have any recommendations and put this patient on their radar. Um, because it helps like when you and that's like a super safe way to say it because it doesn't sound like you over or under escalated. Because
Okay.
like, and
Okay.
then I would
Yeah.
call Rapid and I would tell them like, you know, I'm with this patient. This is what's going on. This is kind of the back history. And sometimes they'd be like, okay, we'll be right there. And they'd hang up and show up. Or sometimes they'd be like, okay, well, just let me know if anything changes. And I'd be like,
Okay.
okay, I guess this isn't like the biggest deal.
Okay.
But yeah, anything where like things could go south very quickly, like Rapid should come by.
Okay. Sounds
Yeah.
good. Cool.
Yeah.
Awesome.
Um, So there's like it's kind of hard to get creative with these, you know, as someone who, like, if you were gonna imagine trying to think up a couple of these questions to like stump someone with. But like the formula that that video gives you gets you like 80% of the answer no matter what they ask you, you know? And then like just know that you have that. And then, um, yeah, I feel like these ones are super intimidating, but like literally what you see is like the same as any like experienced nurse would see, right? Like like you walk into the same thing and know the same thing
Yeah.
and like they have to work it up just like you do.
Yeah,
Yeah.
definitely. I feel like it's like clinical questions are definitely hard, but I feel like I'm so fresh out of nursing school, like a lot of it's still in there. I
Yeah.
definitely feel like I have more hard time with like the behavioral type questions.
Okay.
But I really think that at the end of the day, it just really comes down to just like, for me at least, like just taking a deep breath and just
Yeah.
relaxing because I love to just get worked up. But
And smile if you can to like
yeah,
really like connect with them, show your warmth. Like I feel
yeah.
like that goes a lot farther than people realize.
Yeah, my one of my professors always says your smile is like 80% of your business card. I was like,
Oh, really?
okay.
I like that.
Yeah, really appreciate your help.
Of course.
Definitely helpful. I'm trying not to like practice too much because I really don't want to come off scripted. I just
Yeah.
want this like information in the back of my head because like
You want to
I
feel
realize
comfortable.
exactly. And I've
Yeah.
realized when I'm in the moment, like that's when it pops up. I'm like, oh, okay, this, and it comes out so much more naturally than if I'm
Yeah.
sitting here like practicing over
Yeah.
and over.
100%.
So yeah, I'm excited.